is the course director, who really worked very hard, and he would like to have his two case presentation of 3D transesophageal echo. Rakesh.
Well, I'm going to the last one, but I want to show that like how really we can really change a scenario in our clinical practice by 3 dimensions transesophageal echo. I'm going to show 2 cases, quick, not getting in between you and dinner and drinks. A 39-year-old male serving in military for last 10 years, referred for a mitral valve evaluation as reported by mitral valve prolapse syndrome outside. Look at these images over here. All of us will agree, single one common entity that he has got a mitral valve prolapse syndrome. AML is prolapsing back of flail into AML. He has got a torrential mitral regurgitation. Normal LV systolic function. Again, MR, 3-chamber view. These are all transthoracic images which we recorded before doing a 3 dimensions transthoracic live multi-beat acquisition in this particular patient. Question was, how can a person of 39-year-old who is serving in a military can have a flail mitral valve leaflet? It's impossible. And I'm sure Dr. Anil Dhal, who has served in the military for many, many years, Dr. Y.K. Arora is sitting over here. Nobody who has got a flail mitral valve will ever get into military. And how come this person who is still serving? At least they used to hear murmur. I want one of those rejection from a military from a murmur. They heard a mitral regurgitation murmur in me and they rejected me outside. So that what was the main aim. Let's see like how the 3D transesophageal echo make the total revolution in his images. We often go and do transesophageal echo, 2 dimensions. We all look at 30, 60, 90 degree to look at various scallops. And believe my words, I can never ever remember for last 10 years doing a transesophageal echo, look which one is which. And I often put a chart behind my echo machine and then rotate and see which one I'm trying to do. Or else I'll record 30, 60, 90, 120 degree and then I'll pinpoint one is what is A1, what is A2, what is A3. So that's what I did. I quickly recorded them. I could see a flail leaflet over here. And once we went on to complete evaluation, and that's where we went on finally to do a 3 dimensions full beat multi-acquisition of mitral valve evaluations. And as Luigi is over here, and he categorically says that aorta has to be at 12 o'clock positions. This is AML, this is PML. And look over here, what do we find in this AML over here? This diagnosis of a cleft or a split mitral valve could never have been given without 3 dimensions transesophageal echocardiography. We would have still been struggling without this kind of an imaging technology. And that's what really changed the complete scenario for this young gen. And you know, he comes back with a history. I was serving in Kargil and had a trauma over there on his chest. And ever since that trauma, I am breathless. Another question, mitral valve is posterior, tricuspid is anterior. How can we have this kind of an abnormality? But still, anything could happen. But my quest of showing these images is, look, there a clinical echocardiography, clinical scenario will change completely when we start doing 3 dimensions echocardiography. Let's have the second one. That was still more interesting. And how that was interesting in our clinic practice was, this was one patient came to us for echocardiography. He had his bioprosthetic valve done in one of the institutions in Delhi. And all we can say is a mitral valve bioprosthetic stenting valve is seen over here. And when we switch on the colors, he has a torrential mitral regurgitations. And all of us says like mitral was the first one where we really addressed transthoracic or transesophageal echo was. We looked at 4-chamber view, same patient, and now we can see again a torrential mitral regurgitation. This is single narrow loop 3D echo transthoracic with severe torrential mitral regurgitations. Well, we kept on imaging in transthoracic to prove that whatever we are saying, and we went back again to the same protocol of 30, 60, 90, 120, and 150, 180 degrees of potentials. Now, issues at 0 degree, I could see one stud, other is missing. 2 leaflets are seen. I'm rotating to torrential MR is present over here. I move on to 47, 50 degree. This part of the stud is gone, and we could see this leaflet, something which is collapsing back, and still MR is present. When I rotate this in a little bit on a left or right rotation, I could see a flail leaflet which is being projected into this. If you go back, we could see 2 leaflets, and now I'm seeing a 3rd leaflet which is flail over here. How can this be possible? And we went on to see and do the multiple viewing by 30, 60, 90 degree, and now with a single loop, just adding a depth of a narrow loop 3 dimensions echo, we could see this kind of a picture. But question remains what it exactly this is. How can we have 3 leaflets in a bioprosthetic valve? Obviously, we have to scratch our back, scratch our mind, and still at that particular point, we were looking forward for these kind of, patient had no past records of his imaging, past records of his surgery, and no follow-up echo was seen in this. Look, we went on to do a 3 dimensions transesophageal echo. Now, at this time, I'm not looking from a LV side, I'm looking from LA side. This is what 2-click crop or flexi slices being used in 3D echo. We could see a leaflet, and as soon as I turned around, now you can see looking from a left ventricular side, you could see 1 stud and a 2nd stud, and 3rd stud is already gone over here. And this is a classically Hancock 2 which was used in this patient. And this Hancock 2 was done almost 10 years down the line, when suddenly many people, they started doing this kind of bioprosthetic valves, because they gave a very good idea that longevity of these Hancock 2 is very high. They claimed up to 25 years of a longevity of these kind of valves. And take my words, and possibly you may or may not agree, look, this picture would not have been possible without utilizing 3-dimensional transesophageal echocardiography. So that's what we are using constantly in practice for day-to-day, for our working, for our diagnosis, and subsequently helping our physician or interventional colleagues or our surgeons for their subsequent managements of these abnormalities. Thank you very much for your patience hearing. I wanted to show something in a clinical practice which we have been doing for a long time.
So, ladies and gentlemen, it's a really beautiful expression of power and promise of 3D echo. And I think it was very obvious when Louis Bedano was speaking today that we have to be very selective. We can't use 3D echo as a screening technique or as a routine method. In selective patients, the way Rakesh has shown how the anterior mitral leaflet has a dissection in the army person. It was a beautiful case, lovely case. He's gone to an extent where you could see total division of the anterior mitral leaflet. I think it was really brilliant, Rakesh. It was really wonderful. I think very nice. 3D echo has a power, has a potential. We need to have more experience. Now a final word before we disperse for dinner. Dr. Bedano, your experience, your messages, everybody is looking forward to listen from you, not from me. I'm not a 3D echo expert. Please come here. Come here. Final word of the authority.
Yes, I think as a final word, I have to express my appreciation and thank you to Dr. Gupta for having organized these Echo for Masters together with all the colleagues. I think that organizing a course is always a sort of adventure, you know when you start, but you don't know how it will end, requires commitment, passion, and a lot of work. So I think that he and the team and you all that have been with us so late deserve a big applause and have a good evening. Thank you very much. I really appreciate it.
Thank you very much. I think this message is from a legend, a luminary, a giant of 3D Echo. And I think I'll request all of you, even I tell myself also, that we will try to read his book and learn whatever best we can in our practical. We are very grateful to you, sir, for coming all the way from Italy. Rakesh, you want to say a word? I think let's give a standing ovation with clappings to this great man, Dr. Louis Badano. We feel very proud and privileged to have you with us, sir. Thank you, sir. With this, we request all of you to please join us for dinner. Thank you.